after a while, but I think it's time to start. Could I ask you to kindly come a little closer so it will be more intimate? So you at the backbenchers, could you please come a little closer? Thank you very much. Long shadows. When this conference was planned, a pandemic was a quite probable threat, but still quite theoretical. Now the pandemic is here, probably. We have at least an influenza situation in Mexico and in the USA, which we think will spread to the rest of the world. The first reports from Mexico were alarming. Based on the numbers, an epidemic with high mortality was possible, and of course people became frightened all over the world. And with fear comes irrationality. Some countries wanted to close the borders as if it would be feasible to stop the virus at the border. Others wanted to kill all the pigs, as if pigs were the source of the spread of the disease among humans. And still others wanted to stop import of meat from pigs, obviously assuming that influenza could spread through food. Measures like these illustrate the fact that in certain phases of a pandemic, fear of the pandemic might be a larger threat to the society than the pandemic itself. But of course, even though we might hope and expect that the present pandemic will be a mild one, possibly not very much worse than a hard normal influenza, we still have to prepare for the worst. Even the present pandemic virus might change to the worse in the course of the spread, and of course we still have the threat from the avian flu and several other emerging infectious diseases. Thus, the scope of the conference still is as relevant today as it was a year ago. In fact, this theme probably will be relevant for all foreseeable future. And with these words, I would like to welcome our first speaker, Diana Weil. Diana Weil is trained as a social scientist and has 20 years of experience in global public health policy analysis, program support, and disease control strategy development. She joined WHO in 1991, first at headquarters and then worked at the WHO Regional Office of the Americans Pan America Health Organization and on secondment of the World Bank. She has collaborated with ministers of health in Latin America, Asia, and Africa, and has conducted analysis of the impact of development policies on health, the impact of health system reforms on disease control, the roles for incentives and enablers in service delivery, international financing for TB control, and anti-TB drug supply systems and markets. Ms. Weil has served on numerous interagency panels and committees to devise innovative solutions in drug supply, health systems delivery and financing, and TB care and control. She holds degrees from Brown University and the Harvard School of Public Health, and previous to joining WHO, she was research associate and assistant director of the Takemi program in international health, Harvard School of Public Health. And now she will speak about old Scourge or new crisis. The floor is yours.
Thank you very much. Thank you, Geir, for organizing this, and to others here. It's a real honor to be at this social science forum. I trained, as noted, in social sciences broadly, in political economy, in development studies. And now I've moved more from a social scientist into a bureaucrat, but trying to make the most of our bureaucracy and organizations to work on implementation and disease control. So it's lovely to be here with, in some of the discussions yesterday, around some of the bigger themes that many of us don't have so much time often to discuss and think about. But I think they relate deeply to what we're talking about here today. In presenting the next few slides, I've got a couple of dense slides coming up to try to give an overview of the last 15 or 20 years and what we've been doing. And I think one of the underlying messages I want to bring out today is that while we talk about pandemics, we are not just dealing with the new pandemics, the new emerging infections, but also old diseases that are still with us that may be worsening and also fulfill the characteristics of pandemics, but are often, like tuberculosis, still thought as just endemic diseases. So how do we bring urgency, as we have so effectively to HIV, but to other health problems that for a number of reasons have less attention and are more difficult to deal with in terms of building political support and community-level attention and awareness and commitment to these problems. So only the first two slides are this dense, sorry about this. TB, for those of you that aren't aware, is an ancient and deadly disease caused by inhalation of airborne mycobacteria. So there is some similarity to what we're dealing with today with a H1N1. It is an airborne infectious disease that is spread by coughing, sneezing, and transmission from individual to individual. 1/3 of the world's population is infected with TB, but certainly that proportion is much higher among the poor. One infectious person can spread the disease to 10 to 15 people and many more in certain circumstances in 1 year. But only 1 in 10 people who become infected fall ill with the disease. But if you have a compromised immune system, as with HIV or malnutrition or diabetes, your chance of falling ill greatly increases. We're dealing with a disease that has imperfect tools. We have a 100-year-old diagnostic approach, smear microscopy. While we have some newer diagnostic techniques, none of them is a broad-based point-of-care diagnostic that could really take us into the 21st century. So we're really dealing with a 19th century tool right now. We have 40-year-old drugs. Literally no new TB drug for widespread use has been introduced since 1970. And we have a 90-year-old vaccine, which is imperfect, really only prevents childhood forms of TB disease. So we're in bad shape from the tools perspective. We try to do the best with what we have. But we do know that drug-sensitive TB can be treated and cured with a relatively low-cost combination of drugs. And they're offered free in public services. However, it still takes 6 months to treat a TB patient, and that's far too long for the patient and cumbersome for the health service, and includes a lot of indirect costs. So while drugs may be free in most countries, many other charges are put on the patient. And if you've got drug-resistant TB, it can be 18 months or more to get treated. And then related to that, it's much more toxic, much more complex treatment when you get into drug-resistant TB. And that's exactly why we're so concerned about the pandemic, the rising numbers of drug-resistant TB worldwide, because we could be looking to an era in the future where we're facing untreatable tuberculosis. It's not inconceivable. Where have we come since the late 1980s? And this all happens within the context of global attention or lack thereof for public health and for primary care over this period. In the late 1980s, TB was falsely perceived to have gone away, both in the developed world and the developing world. There was a sense that we had drugs available, we had vaccine that was available, and there was lack of energy. And there was a primary health care movement with the intention that that ambulatory care would be offered worldwide. So we lost attention on TB. At that very time, around 1990, though, TB reemerged in the US and Europe, and that was for a combination of reasons. There was the HIV epidemic began to emerge. We had rising homelessness. We had a reduction in the strength of public health infrastructure particularly if you look in some of the European and US contexts with primary healthcare infrastructure, basic clinics, lost their manpower to be able to deal with basic problems like tuberculosis. And of course, in the former Soviet Union, as you'll see later in the presentation, there was the emergence of drug-resistant and drug-sensitive tuberculosis with the breakdown of the Soviet Union and the breakdown of public health structures and drug supply in that region, and an ongoing, very heavy burden in Asia. So through the 1970s, 80s, we had well-established TB programs worldwide, but they weren't very well manned, and they were only doing the bare minimum of what needed to be done to mount a national control effort. So in the early 1990s, WHO announced a public health emergency when people became aware that TB was reemerging in the developed world and had never gone away in the developing world. And the World Health Assembly set targets, which we all know that there are strengths and weaknesses to setting targets, but it certainly put some attention to the world of where were we relative to the very weak status in terms of reporting cases and reporting on what happens to cases worldwide. WHO promoted an approach called DOTS, which was a basic package for TB control based on smear microscopy, political commitment to a national TB control program, standardized therapy where most of the world they were using non-standardized regimens and had irregular drug supplies. There was a focus on information systems and a focus on really organizing a national effort to respond once again to the disease. So it became a public health approach again after it had sort of lost its focus on public health and had been focused on clinical disease. There was consensus around WHO policies and tools, and I think this is similar to what we're dealing with right now with this current pandemic, is the challenge of how do you bring the world to look at what should be the common approach to attacking a health problem. And the more consensus there is, the more consistency in the policies being applied, the better individual countries can deal with the disease and the better countries can collaborate in responding. So that was a real strength for us, that there was consensus on basic tools. We had coordinated technical assistance for national plans. We formulated national plans with governments. We assisted them, and with various technical partners, we were able to assist the initiation of implementation of scaled-up plans to respond. And we began to deal with the very thorny challenges of drug-resistant TB and HIV-associated TB, which I'll talk about later. We had the World Bank and bilaterals that engaged in the challenge. We had the formation of the Stop TB Partnership, which for those of us, we now deal with UNAIDS. We know that we have the Rollback Malaria Partnership. We have the Global Fund. We have many partnerships out there. But in the year 2000, there really weren't that many partnerships at that time, and it changed the way that we looked at how we could collaborate with civil society, with NGOs, with donors. So I can't underline enough the importance of a partnership approach. We created special mechanisms like the Green Light Committee to give concessionally priced drugs for drug-resistant TB to programs that were vetted for their quality and safety in applying those drugs. We created a drug facility for engaging active access to low-cost, high-quality confirmed drugs to particularly poor countries that were spending most of their time worrying about procurement and securing where they could get the money for their drugs and arranging contracts. So this drug facility has reduced the burden by so many countries on what they needed to focus on. Then we had the Global Fund to fight AIDS, TB, and malaria was created, and this was really a pathfinder and sea change for the resources available to scale up efforts. And then, as many of you know, the Bill and Melinda Gates Foundation was created and started to invest in research, which had been forgotten so long, as well as to fund strategic efforts around implementation that we collaborate with extensively now. We created a first global plan that mapped out how we could deal with multiple problems at the same time across regions with particular approaches by region. And as a result of all this, we did help countries treat, as of 2006, a total of cumulatively of 30 million patients who previously, in the absence of this approach, been treated, as I said, under non-standard approaches without much care on what was happening to them as results, much focus on getting them detected, but not on their results. So here we're focusing on how many people are treated and how many are cured as a result of that treatment. So there was massive scale scale up, particularly in China and India, and work in Russia, particularly around getting the Russians and Eastern Europeans on board with new strategies to fight the disease. And I wanted to note, given some discussions yesterday, Paul Collier's talk on fragile states, that we did have examples of where TB was dealt with in fragile states in places like DR Congo, in Somalia, in Haiti, in Afghanistan, more recently in Cambodia, in its recovery process. And this was largely linked between government policies being implemented through NGOs and working in partnership to get that job done. There is still a long way to go for fragile states, but at least we can show some results from that. But we're still facing a challenge. The scale-up is incomplete, and we've had insufficient impact. So I'm going to give you some more details in this regard. Here is just an overview, again, of our targets. We have the Millennium Development Goals, where TB isn't a named element of the title, but Goal 6, but it's combat HIV/AIDS, malaria, and other diseases. There is a target within there and indicators for TB within that agenda, and this has been tremendously important to refocus our attention to addressing multiple diseases at once and to really focus on turning the epidemic around, turning incidence around. We also have other targets of having mortality and having prevalence due to TB, and with the high hope of eliminating TB by 2050, but there's no way we're going to be able to do that unless we have new tools. We know that now. One thing I wanted to note, and this came up, I think, in Amartya Sen's comments yesterday, as well as what I heard Paul Collier speak about, is that when we think about national averages under the MDGs or global averages and how we're doing aren't sufficient. We really need to be looking at locally specific results, particularly for the poorest, and this is something we're increasingly looking at now for TB. And this has to do with, as well, the movement in HIV/AIDS to say that we're terribly concerned about universal access. We need to have access by all to achieve results across the globe. As I mentioned, we have a vision. We had a DOT strategy, and out of our experience in the first 10 years of efforts, we revised that strategy and created something called the Stop TB strategy, which I'll go into in a minute. But that gave us a new broadened vision of what we needed to do in the context of health system strengthening, in the context of a focus on poverty and development. And we had a global plan, a second global plan, that really focused in on what was it going to cost to really scale up to meet these targets, the incredibly ambitious targets that have been set. And as you can see in the numbers in the middle, it's quite dramatic, those numbers of what it will take to meet the MDGs. So this is only one of the MDG goals, and you're looking at billions of dollars, $56 billion to meet the goal by 2015. Here's our latest data from we released this March to say we have 9.3 million TB cases in the world each year with about 1.7 million TB deaths. Of those, we have about 500,000 MDR-TB cases estimated each year. That estimate is quite weak. We still need a lot of work on estimation processes with countries to do more surveys. You'll see this next. And about 150,000 deaths attributable to drug-resistant TB. Extensively drug-resistant TB, XDR, which received a lot of attention over the last 2 years by the media and by countries' concerns, including the developed world, has emerged. We have good documentation about it. It's a much more lethal and problematic form of drug-resistant TB, with about 50,000 cases we estimate worldwide and 30,000 deaths. And importantly, HIV-associated TB, as I noted before, immunocompromised persons are much more susceptible to TB. And TB patients are very likely to be HIV positive, particularly in Africa, where up to 70% of TB patients are HIV positive. We've just done re-estimates, which were very important this spring, which show a much more dramatic burden, 1.37 million cases and about 456,000 deaths. About a quarter of all deaths are attributable to HIV. The important thing to note on this slide, which shows you the trends and incidence worldwide, is the red line for Africa. As you can see, it rose dramatically from 1990. As you know, that's largely associated with HIV, but we also believe it's associated with the weakening of public health infrastructure in that region as well. In other regions, we saw increases and then stabilization, such as in Eastern Europe. And in most other regions, you can see that it's basically stable or falling, but falling terribly slowly at about 1% globally per year. So this is not the trajectory we were hoping for. We were hoping for aiming with our scale-up of efforts of 5 to 6% decline per year, but we have some reasons why we think it's not declining that fast. But while the rates are beginning to go down, so we've achieved the MDG target, the number of cases continues to rise. So this is still an epidemic. The numbers of cases are continuing to rise. This is not a static situation. So unless we can ratchet up our efforts even further and overcome the population growth factor, we will still see more cases and more deaths per year. Just to show that this is a global pandemic, that we have a burden in every single region of the world. The greatest absolute burden is in Asia. The greatest rate burden, as suggested by the last slide, is in Africa. But as you can see, there's ongoing burden in each of the other regions worldwide. We had these targets of having prevalence and mortality by 2015. And as you can see, we are having some effect. We've been able to show that the efforts in China, based on our DOT strategy, did lead, where it was first instituted, to a reduction by 1/3 in prevalence. Basically, you were beginning to get all cases that had previously not been dealt with into treatment and cured. But it still wasn't dealing with the thorny issue of how do you get patients earlier and faster to stop transmission. Mortality also is declining, and this is one of the great things about getting people into treatment is their likelihood of dying falls. But it's certainly not falling at the rate we need it. Two slides. The left slide is a little bit complicated, but I want to just show you that the red dots and the blue dots on the left, this is case detection over time. The red dots were all cases that were notified in the country. Not all cases in countries are notified to the national governments, but of those notified back in the mid-90s, most cases were not on quality treatment, such as the DOTS approach back in the early 90s. But over time, we've seen a convergence of the two lines, the blue line, those cases under DOTS, and those that weren't under DOTS. So we've been able to cover cases that hadn't been treated under standardized programs, but we're still not reaching out to that rest of the 30% that haven't been reached so far, that are either in the private sector, not being detected at all, or going to pharmacies. And that's one of our biggest challenges I'll be talking about next. Treatment success, we know that when we get people into DOTS programs, they can be cured. They do adhere, particularly if they've got community-based care with volunteers helping them to take their medicines and get support they need. So the treatment results are relatively good, but we do have regions, as you can see on the right in the note on the bottom, that still have very low success rates, like in Europe, and that has to do with drug-resistant TB and some of the barriers, for example, in Africa and even parts of Latin America where the poor aren't able to continuously access services. I said before that we weren't going to reach TB elimination, and this graphic just shows you the reality of why. We have targeted, to reach elimination, we'd have to be seeing reduction in incidence of 16% a year, which is the green line. We're nowhere near that right now. Right now, where the current trajectory is the black line. If we pursued what we've done under our current plan, we'll reduce by 6% per year. So this all tells us that without a new vaccine or a new point-of-care diagnostic or a 10-dose antibiotic cure for TB, we're going to be in bad shape for our aim to eliminate TB in our lifetime, or our children's lifetimes. We have a strategy, a revised strategy that's more expanded, that deals with the broader context of the challenges today, that we feel is quite robust as a policy for countries to follow. What we know is in practice, it's a quite ambitious approach to take on. It's similar to when you think about maternal mortality, what it takes across a health system to deal with the complexities of that health issue. Same thing with TB. It's not like a vaccine preventable disease where you can give one dose and prevent care. You have to deal with the entire health system here. So we want to do basic DOTS, but we also want to address these special concerns of TB, HIV, MDR-TB, and special focus on poor and vulnerable groups, which we'll come back to. We want to strengthen systems. We don't want to operate in isolation. This is not a vertical program that operates outside the health system. It operates via primary health care. So we have to work with other programs, which we're doing now, such as malaria and HIV and maternal and child health in all its forms, to try to do more to strengthen primary health care. We want to engage all providers, and I think this is, in my next slide, you're going to see is the most dramatic thing. One of the things we have to do now is that unless we engage all those in the health system, not just those in the public system in primary health care clinics, but in public hospitals that operate on their own often independently, or private providers, or drug sellers, we won't solve the problem of this disease or in many others. We also want to empower communities, or have the communities themselves be empowered to engage and demand what needs to be done to serve them better, and we need to promote research. When we think about the HIV problem, I just wanted to show you that clearly the HIV-TB burden is largely in Africa, and if you look at that burden alone in South Africa, we have a tremendous problem in Southern Africa today. And we really are beginning to recognize, or have recognized, and are beginning to act, particularly with the new government in South Africa, the interim government the last few months, and the new government that's just been sworn in, to address the special needs of that context, of extremely high HIV rates, of the highest TB rates ever recorded even before the HIV epidemic hit, so much worse today, and a complex social and economic situation with lots of migrant workers affecting all of Southern Africa because of this situation. We have seen some success in HIV testing for notified TB patients. As you can see, the map is showing the numbers of, a proportion of patients that have been tested for HIV. And as you can see, the red is we have countries that now have up to 3/4 of their TB patients are being tested for HIV, which is the first step to get them into better care, to get treated for HIV, to get treated for other opportunistic infections. But the problem that we're seeing is that once they get tested now, we still don't have full access systems, integrated access systems for HIV care, and vice versa. HIV patients, people living with HIV need to be screened for TB, and that system is still quite weak, but showing progress with new initiatives like the Global Fund and PEPFAR and others. Now on the MDR front, this is when we talk about pandemics, and I know we'll be hearing more from Elizabeth on this, is the issue of the media. Now, MDR-TB is something that does bring the attention of the American and the European public to bear, because it is a scarier form of disease. It's something we haven't seen largely before. It leads to high death rates. In fact, in 1990, TB wouldn't have gotten back on the global stage if it hadn't been for a prison guard who was infected with drug-resistant TB in the US prison system. If that prison guard hadn't been infected, it wouldn't gotten across the news, across the newspapers, and there wouldn't have been the attention in the aid community to refocus on TB a bit. But we have this challenge on our hands that this is an enormous problem. We don't have great estimates, but the estimates we have show a grave problem. We know that under 5% today of those patients who have drug-resistant TB are accessing care. We have an approach in place to try to expand that care, but many bottlenecks that I'll just present in a minute. And we have about 27 countries that carry a majority of the burden, and some of those countries are very complex countries. I mean, difficult countries in Eastern Europe with complex political situations, and massive countries like India and China, where scale-up is going to be quite challenging. We just had a meeting in Beijing that Bill Gates and the Vice Premier of China attended a month ago, in which we brought high-burden countries together to face some of these real bottlenecks. And I think politically, and for social scientists, and I think we have to recognize, we all know well that getting on political agendas is difficult, and staying on political agendas is even more difficult. But the first step in dealing with MDR-TB is to getting these countries to sit down as they did and begin to talk about how would they put together a national response plan. You see much more rapid action happening right now with this current pandemic. But for MDR and for TB in general, we've been faced with the challenge that Minister of Health in Francophone Africa said to me once that TB is like the big old aunt that sits in the corner. She's always there. She's always a little belligerent, but she never, she's just sitting back in the corner. And I think the reality for us is how do we recognize and engage to ensure that people recognize that she can become a lot more belligerent, a lot more violent. And sitting in the corner is not going to be a way for us to address the real problems that that old aunt has. So we need to address MDR right on the mark. And one of the key challenges we found is something we haven't dealt with very well, is regulating the private sector, private sale of drugs. We have fluoroquinolone antibiotics in hospitals, in private drug sellers all over the world. I was in India last week. You can buy any fluoroquinolone in any tiny pharmacy, even in rural India. There's a proliferation of supply, very little control, very little regulation. This is one of the most challenging global challenges we have right now, and how to restrict that supply now that it's out of the bag. Now that it's already widely available, how do we rein it back in? This is just to show that you see the red, that MDR is particularly prevalent in Eastern Europe for a variety of reasons of how it emerged in the 1990s, but it's certainly prevalent in other countries. But as you see in this graph, as well as in the next graph on XDR, you see a big gray hole in Africa. And that's not because there's no XDR in Africa. There probably is less XDR than some other areas, but the fact is we don't have the diagnostic capacity in Africa to detect the problem. So until we build up the laboratory systems in Africa, we will be nowhere in addressing this problem for the future. So that's why a major focus of our work today is bringing attention through new mechanisms to get diagnostic supplies and new diagnostics out to the regions where they need it to measure the problem and to respond. Bertha, unfortunately, is not with us today, and so that's why we're taking more time now in presenting. Bertha is a colleague from Malawi who'd worked extensively with myself and others in our Stop TB partnership on poverty and TB control and other health problems, and really focusing on the barriers to accessing both TB services and other public health services for the very poor. And one approach that's been brought on board, an innovative approach done by a group called the World Care Council, was to create a charter, a patient's charter for TB care and control. And what it does is to lay out not just the rights of patients to care and to dignity and information and to choice, to privacy and to the right to complain about how care is being provided, the right to organize themselves, and the right to security while receiving care and safe care. But also the responsibilities that come with being a TB patient. And this brings out the issues that this is a communicable disease and that one needs to share information about the disease that you're affected by. You need to follow treatment because in failing to follow treatment, you could be transmitting the disease to others. You need to defend your own community against that disease and against interests that may not want to expand public health action in those communities. And the responsibility to be empowered, to be engaged, and to respond to this problem that affects not only individuals but whole communities. We've been focusing a lot more in recent weeks and months on the human rights approach, and this has come largely from the HIV community that has gotten deeply involved in TB control more recently. And with UNAIDS now, the new director at UNAIDS has taken on TB HIV as one of his top issues, and Peter Piot, who's with us today at this conference, had raised it up as a major concern during his long tenure at UNAIDS as well. And I think we can learn a lot from the HIV community around the rights-based approach to TB. TB was largely a medical and public health approach for many years. Patients don't perceive themselves to be TB patients. They perceive themselves to be people with cough. They don't live a life forever as a TB patient, unlike somebody who lives with HIV. You either get treatment or you don't get treatment. If you do get treatment, you may be cured and you may walk away. So the question is, how do you bring people the identity of wanting to be engaged in TB and other public health challenges for their community? And how do we face the particular human rights concerns of a whole group of special vulnerable groups that are listed up here? There's a wide array of groups that have particular risks for TB, and the approaches to dealing with their TB problem and their public health needs in general are quite distinct, and we're trying to work on strategies across these. We also have to deal with the underlying risk factors for TB. There's been a lot of research done, for example, on the relationship between TB and tobacco, that if you're a smoker, you're more likely, if ever infected with TB, to fall ill. And if you fall ill, you're more likely to die. So the relationship with how to deal with the tobacco epidemic as it rises in the developing world is a very daunting one for the world in general. But for TB programs, it's also a scary one because it means likely more disease, but also an opportunity to engage in tobacco prevention efforts. I just wanted to show, you may not be able to see the details here, but Africa and Russia, we have two different scenarios of risk factors. In Africa, you can see that HIV, malnutrition, and indoor air pollution are dominant concerns of risk factors for TB. In Russia, however, smoking, alcohol use, as well as HIV are more dominant concerns. So this just reinforces the profile of who is your community that's at risk, what is the context in which they're becoming at risk? How do you respond to those risk factors and to respond to disease programs that need to be varied because of that? I wanted to come back as I move to toward the end of this talk is how do we engage all care providers? Because as I said before, if we don't get out to the private sector, if we don't engage both through regulation, through carrots and sticks and incentive systems and partnership, we will be nowhere with the TB problem, particularly in Asia where the private sector is so dominant. I show a Russian prison on the left because, as you might know, military systems, prison systems, and others have their own health systems. They're not necessarily integrated in public health systems more broadly. And where the risks are so great with TB and drug-resistant TB, you have to deal with that broader context of working with those health systems, which is not easy. We've succeeded in working quite well in Eastern Europe, but in much of the rest of the world, there's almost very little being done in the prisons to fight TB and often HIV. On the right is an Indian street scene. Many of you who've visited India know this, that you have a pharmacy, a chemist on most blocks, as I mentioned, with antibiotics and many other things to sell, and it's sell at low cost without prescriptions or with faulty prescriptions. This slide is a slide from Kenya, and Bertha has been involved in related work around this. This was work done in Kenya to show that TB patients, there was a profile done on where do patients with TB symptoms go, where do they go to seek care? And a majority of patients go to the first level of care first, the local dispensary. But what was found was that for patients participating in the DOTS program in TB, dispensaries were not very engaged. That's the top right column, showing the dispensaries were not as engaged as hospitals and health centers, but you're missing that first level of care. So patients come into a dispensary, they may not get treated well or detected early, and they walk away. They may go to the private sector, or they come back and it takes them months to get detected. So for us to achieve more for the poor, we need to get to where the poor are reaching care early, to detect them early. Similar example in China. I won't go into detail on this slide, but just to say that a prevalence survey of TB was done, and they detected a lot of TB patients that were they found a lot of patients that were in treatment, but hadn't been notified to the national government. And many of those patients were going to general hospitals. They weren't going to the standalone TB clinics that existed. So the key was to how do you bring in those hospitals? And the SARS epidemic helped open that up. The SARS epidemic led to much greater reporting requirements across the public health system for reportable diseases. And so TB became a reportable disease. Now hospitals do report their TB cases. And the reason they didn't report before is that they used to charge for TB care, whereas TB care is supposed to be now free in China. So how do you overcome that financial disincentive to participate in TB control is a big issue. In India, and this is what I saw very dramatically in the last few weeks, there are a huge array of people providing care. In one example in Mumbai, you can see with these graphics here that by involving TB hospitals, NGOs, medical colleges, private providers, you can increase the number of patients being treated. But the challenge is to do that on a massive scale in India. It worked in one location in Mumbai, but to do it nationally is incredibly challenging. And we haven't really figured out a way to help the Indians do this on a massive scale. I think it's going to take more private initiative, it's going to take more monetary incentives and disincentives, and certainly more regulatory structures. So we want to empower communities. And I think there's an example on the left here of a community health worker in South Africa. Throughout the world, we're seeing the rise again of community health programs, such as lady health workers in Pakistan, extension workers in Ethiopia. These are incredible assets for TB control and other outreach programs. But in TB, we don't have the energy the HIV community had, and even child health community has. How do we engage with those other endeavors to reach out and use those community workers to get the messages out about a disease like TB, or even in the future about diseases such as H1N1? We know that cured patients, where they're used, can be incredibly powerful speakers for addressing a problem like TB. They know that they can be cured, they can help others to seek care and be cared for. And we show in Bangladesh that there was less delay in finding patients early when you use cured patients, but most countries aren't using this yet. I want to end with the financial crisis. We know that TB has lessons to be learned from the past on what happens in the case of a financial crisis or a political crisis. And TB, we know from the world wars that TB dramatically increased leading up and during the wars, but also in Eastern Europe, as I said, TB emerged dramatically with the breakdown of the Soviet Union, and even in Central Europe it was affected. This slide simply shows that from 1980 to 1989 there was a steady decline in the number of TB cases being reported. And then something happened in 1990 with the financial and political crisis, that GDP, which is the axis on the bottom, declined. GDP per capita declined. And with that, there's an interesting correlation with TB case rates, shot up between 1990 and 1994. And then they began to decline again from 1995 onward, but much slower. And our epidemiologists are suggesting that that might have actually been a 5-year loss in the efforts to control TB. But what happened here also was we had the emergence of drug-resistant TB, which hasn't gone away, which has gotten worse in that region as well. The other one is to show that different countries deal with the epidemic in different ways. And what we saw in terms of case fatality with the crisis that hit in the former Soviet Union is that Hungary saw an increase with its economic crisis. It saw an increase in cases, but it didn't see much of an increase in deaths, whereas you can see the dramatic rise in TB case fatality in Russia because of the much more acute situation it had with drug supplies, with the prison system, and other issues. So trying to prevent this kind of scenario happening again with the future financial crises that some countries are facing is one of our predominant concerns. WHO and many ministers of health have worked broadly on addressing how is global health going to be affected in the financial crisis. And some of the issues that we've brought up is the issue of leadership, recognizing that global health and public health needs to be protected in the time of financial crisis, just as this current pandemic is showing us. Also showing that monitoring and analysis is going to be critical. So we're trying to work with governments to quickly assess where TB cases may be rising due to in-migration back of laborers that lost their jobs, or those that have government spending has reduced quickly on commodities where there may be a reduction in supply of drugs. This kind of M&E function is critical. Another thing is we know the lessons learned is to spend on the poor. Pro-poor spending is critical in times of financial crisis, as well as pro-health spending. In many governments, we have seen a decline in health spending in past financial crises. Some governments have prevented that, some have done less well in that. We need policies for a stronger health sector, better efficiency in spending in the health sector. And lastly, we need better ways of the world community, when it's giving assistance, to work in a collaborative fashion to be sure that the resources that are continuing to be spent for global health are used efficiently, and not through little micro projects, but through large programs that are endorsed and owned by governments themselves. We have huge financial gaps that persist for TB control. I won't go into detail here because it's true across maternal health and child health, and even for HIV, insufficient financing. But measuring this is one of the key things that we think we need to do, both social scientists can help to do, to examine spending patterns and trends, and what we need to do to keep track of where we're going and where the biggest gaps are worldwide. So to end, we have examples of needed social science analysis. Some examples are, how do we address political complacency? How do we address stewardship and management capacity building? How do we improve effective health provider regulation and drug producer regulation and motivation? We may have better lessons in other fields than we know in our field. How do we support patients and communities better to increase awareness and their own demand for their own needs and engagement, and to reduce those massive barriers to care that we know persist? And how do we learn from human rights experiences and experiences in dealing with the determinants of disease and reducing those? Michael Marmot will be speaking about that today. And to estimate the health and economic security impact of acting or not acting on TB. Certainly there's lots of discussion today in the existence of H1N1 about what the impacts might be if we don't act quickly to curtail or stop this pandemic. The same is very much true for TB. A World Bank study suggests that we can governments can benefit 10 times greater benefits by investing in TB control than the cost of those investments up front. But the scarier scenario that we really need to study is if we don't act today and we face MDR patterns increasing dramatically and becoming the dominant form of TB, which is potential in some countries in the future, what will be the economic costs for that? And what do we do if we haven't invested in the research for new drugs in the face of that drug resistance? So those are tremendously important research questions that we need help in answering. Thank you.
Thank you very much for a very interesting presentation. Before we move on in the program, we'll have some questions and comments, but before we move on, is Lotte Njurenda arrived yet? No. Then I presume that this presentation will not be held, and then we have more time for these two speakers. But are there any questions or comments to this speech? Yeah? Good. Then will you please use the microphone?
Yes, thank you very much for a very interesting and very engaging presentation. I have two questions. One has to do with the multi-drug resistant strains. In decision theory, they have an expression which is called rational fear. And one of the good things one could say about the AIDS epidemic was that we learned in the early phases that we did not have to be afraid of those that were infected. We could hug, we could kiss, we could do all sorts of things with people who were infected with AIDS. So don't worry was basically the key message here. Now with the multi-drug resistant strains, we are in a very different situation with tuberculosis. And that is therefore also what I would like you to elaborate on is what do you think are going to be the behavioral implications of the fact that we may now have to be much more protective, and not only in relation to patients with tuberculosis, but of course also then patients infected with AIDS when you have the co-infections. So, and also if you could reflect something on whether we in fact may be going back to a situation where we regenerate the prejudices that were very prevalent in olden days in relation to tuberculosis, and for good reasons. So if you could comment some on that. The other is which you indirectly commented on when you said or addressed the need to have programs that address the needs of the poor. One of the things you did not comment on explicitly is the increasing food shortage and the possibilities also of increasing hunger, a couple of 100 million more now than just a few years ago, and also that the Millennium Development Goal on hunger is not likely to be reached. And clearly, I would imagine, based on historical experience, that you would expect also that to increase the susceptibility to the infection.
Okay. So,
Yeah, I think you've raised on the first point an absolutely critical point, and we saw this acutely, the issues around fear and MDR-TB in two cases. One was the case of Andrew Speaker, who I shouldn't really refer to his name, it's unfair to him, but as an individual who became famous in the press worldwide when he traveled from the United States to Europe with drug-resistant TB. And that became a major story and a homeland security issue in the United States, led to hearings on Capitol Hill. It was one patient with drug-resistant tuberculosis who traveled. We know that thousands of people are crossing borders every day. There are many of them have drug-resistant tuberculosis. We're not detecting it today. So there is a fear factor that's there. Now and more importantly, the other example is the case of South Africa, where because of the emergence of extensively drug-resistant TB in settings where patients were coming forward for HIV care, it was basically a tinderbox where there was an outbreak in Tugela Ferry with MDR-TB, where the patients were all detected shortly before their deaths. 98% of the cases detected with MDR-TB died. And that was in an environment where most of the patients were immunocompromised. They were in a congregate setting. There was no infection control, and there was quick death. Those two circumstances have led to certain calls for isolation, restrictions, detention, and we've actually started working with a task force on ethics in TB to discuss some of these issues. The reality is that in most of the world, we're not detecting most MDR until after all the infection has already happened. So how much are we doing if we isolate patients in hospitals that aren't set up for an infection control, detaining them for large amounts of time? That should really be only a measure taken in the very, very odd circumstance of somebody who won't take drugs, who won't participate in public health operations, and that we apply certain Syracuse principles to that case. But in most cases, for example, in India today, I was just working with a TB program in India, and we're working with the South Africans to come up with ambulatory care models for MDR-TB. Because with most forms of MDR, you can treat it quickly. They become non-infectious relatively quickly under treatment. You can provide safe models of care in the community or in hospital and outpatient settings. So to reduce that fear factor, to make it a treatable disease similar to the HIV, I mean, when you transform it from something that is untreatable, perceived as being fully untreatable, to something that we do have a model of care that does involve the community, it changes completely the notions of the fear of stigma and other things. So in India, for example, it's going to be an ambulatory care model for MDR-TB. For true XDR-TB, there is likelihood that isolation will be an issue, particularly since it takes longer for people to become non-infectious. And that means setting up models of care that are really respecting human rights, even in the need to hospitalize and to isolate patients for periods of time. So I think the issues of dealing with stigma, we saw in India this trip, I was astounded by how little stigma there is with HIV in many locations now, because treatment is beginning to be available and there's been so much education. So similar for TB, the more education on curability, even in India today, it used to be perceived once a TB patient, always a TB patient. Women could never marry if they ever had TB. Now you see people do understand it's a curable disease, and so the stigma is reduced. On the second point that you raised, regarding, now I'm forgetting, regarding issues of poverty and malnutrition, clearly we know from the world wars that the thing that affected probably TB most was the reduced food supplies and rationing, such as in the Netherlands, where you saw an absolutely astounding rise in TB associated with that rise in malnutrition. So we are actually at a weak point in terms of measuring what that potential increase could be with increased food insecurity. And we have seen waves of this, acute waves, even in Cuba in the late 1980s, where TB emerged as a problem because of acute nutritional problems. So we do need to be attentive to this. We are working with the World Food Program so that, in fact, food support is being something that's being provided to TB patients and their families, just as with HIV patients. So that's one tiny measure that can help when we already detect TB patients. But it is a prime concern for us to think about in the coming weeks and months.
Thank you. Lady in Red is a famous movie, but also the next person to question us.
I'm Jenny Popey from Lancaster, and I did some work. I did a systematic review of qualitative research on TB, and there were two things that came out of that work for me, and I wanted to ask you what had happened with there seemed very little evidence that the observation bit of DOTS was the mechanism, to use a term that's being used a lot today, in delivering these astonishing cure rates. It seemed more to do with the improvements in the system than it had to do with observation. But the observation seems deeply rooted in our mistrust of poor people, that they don't behave very well, and we have to kind of observe them to make sure that they behave in ways that we want them to behave. So is STOPS TB moved away from that notion of observation? Because it can be quite an expensive aspect of the delivery, but it can also link into the stigma stuff. So that's one thing. The other thing that I wanted to kind of comment on really is you didn't mention the risk of reinfection in the context of a world which is becoming more unequal and where poverty is becoming more of a problem, really. And I have no idea how severe a problem that is, but it looks like it could get much, much worse. And pro-poor seems to be about directing healthcare resources at the poor. So the extent to which the program, the Public Health Priorities Program, is linking in with the poverty reduction programs, which seems to be the primary action that we should be aiming for, really.
Those are great and challenging questions. On the issue of directly observed treatment, some of us have never been great fans of that term, although I think many of us are fans of the need for patient support and guidance during treatment. Directly observed is a nasty way of phrasing it, I think. But I think we recognize that the reason that directly observed treatment is provided is not only to enhance adherence, but to prevent drug resistance, the emergence of drug resistance. And I think what our systemic reviews have shown is less clear than what you may have suggested. What we have shown is that programs, it's hard to tease out the variables that matter most in those programs. But to stimulate supervision and support programs for patients during care, not just in health centers, not observing just the poor, and it's not because of the distrust of patients. It's some of the wealthiest patients in New York City were also poor adherers, which led to the original practices for DOT in the United States when drug-resistant TB emerged. But it's much more the issue of the sustained support that's needed to get through a 6-month course of therapy. We know in most cases that DOT is not always rigorously followed every day, but we also know that self-observation has never worked. I mean, self-treatment without support systems, without assurances that patients are taking their pills, doesn't work either. How to do that creatively in a way that's supportive of patients and not restrictive of patients is the key concern. So I think in the light of drug resistance, we're more than ever concerned about having fully patient support and supervision of supervisors who are supporting that patient. It's absolutely critical, and we have no studies that have showed that do that follow-up on the emergence of drug resistance. That's our challenge, but we fear it greatly, and we know that it has emerged where non-adherence has been an issue. Regarding reinfection, we don't have such knowledge bases of rising infection levels in the world, but in terms of the potential for reinfection, it just reinforces the need for early detection, better diagnostics to detect patients earlier before they infect others, and that's our biggest concern today, is getting a better point-of-care diagnostic to support the work. And lastly, on poverty reduction, I wish poverty reduction strategies were really being promoted as widely as they had been initially. I think a lot of us have seen a lot of effort on the development of strategic plans, but how much are they being put into play is another issue. In some countries, for example, what I've just seen in India, I keep bringing up this example because I was just there, but there is a new rural health mission focused on both rural health development in India and health systems development. And that's incredibly powerful for reaching out for diseases like TB. So I think you're absolutely right. Working abroad across poverty agendas broadly and not just exclusively on one disease is the way to go. Thanks.
Thank you very much, Diana, for a nice presentation. And then we will move on to the next speaker, who is Elizabeth Pisani. And that's one of the social researchers that will not describe herself as a social scientist, although her first degree was in classical Chinese. Her master was in medical demography, and she has a secret past as a reporter on politics and economy. As she also has a PhD in infectious disease epidemiology, it would be probably better to call her multidisciplinary. For more than a decade, she has worked in HIV surveillance, prevention program planning, and program monitoring. She was closely involved in developing the WHO UN AIDS guidelines for second-generation HIV surveillance, and has been active in developing methods for behavioral surveillance, population size estimations, data management, and program planning. Most of our work has been in support of Asian governments, including those of Indonesia, China, East Timor, and the Philippines. Fieldwork and methods developed with colleagues in those countries has contributed to several technical modules in the WHO's HIV Surveillance Working Group series. As anyone who has read our much less technical book, The Wisdom of the Horse, will know, Elizabeth makes no secret of her frustration that a welcome and necessary political dedication to increasing access to HIV treatment has not been matched by a similar expansion of effective HIV prevention services. For the time being, Elizabeth Pisani is an independent consultant in epidemiology, working for Wellcome Trust, the Government of Canada, and the World Bank, among others. And thus, we look forward to hear about panic in perspective. Thank you.
I'm not there, but I'm not here. Oh, I need to use the remote. Thank you. Okay, now I'm talking a bit about the media and their relationship to pandemics because I did have a secret past, as you've been told, as a journalist before I became an epidemiologist. And when I was asked to speak on this subject, I planned to speak largely on HIV, which is the pandemic, we'll talk about that, that I know most about. But of course, we've come at this extremely opportune moment to talk about the media's role in beating up, as we call it, pandemic stories in the light of the swine flu epidemic. So I wanted to talk about creating pandemics and whether we actually can create pandemics. It's actually not that easy to do. A pandemic, and pandemic of influenza particularly, requires three things. We need a new virus, or a virus which is new to humans. We need that to be able to be transmitted from one human to another relatively easily. We need that to be able to happen over a wide geographical area, so it can't be constrained by things like climate. And that epidemic or that new virus has to cause, at the very least, severe illness and probably quite a lot of death. So how are we doing so far with new pandemics? Well, not very well. The swine flu one, you can see the data here, basically does transmit quite readily, apparently, from human to human, but doesn't make people very sick and doesn't kill very many people. So globally, we've got fewer than 0.1% mortality from the notified cases of swine flu. Now, we're probably getting the deaths notified. We're much less likely to be getting the cases notified. So that's an absolute maximum level of mortality. In Mexico, it's much higher, but it's still at under 3%, and again, that's of notified cases. So is that a pandemic? No, because it doesn't meet the criterion of actually making people really sick and or killing them. Avian flu, as you can see, does kill people. 61% mortality, and in Indonesia, where I've worked for many years, we're talking 85%, but it doesn't transmit from human to human yet. So in fact, that's not a pandemic either. So at the moment, we don't have much in the way of pandemics that are newly created. What we do have is a pandemic of media coverage. So this is coverage of pandemic flu, avian influenza and or swine flu since 1997. I've tracked all of the US media and wire services and the New York Times just to show you how close the whole of the US media sticks to that bellwether, the New York Times. And you can see there was a massive peak at, in fact, just the end of 2004. So that peak 2004, 2005 was actually just between essentially November and about February, at around the time that the Bush administration finally, 3 years after the first human death of avian influenza, got together their pandemic response preparedness thing. Why did they do that finally? Well, because, let me see, the Bush administration's poll ratings were at an all-time low, not least because of their complete failure to respond in any adequate way to Hurricane Katrina. So suddenly it was like, oh my God, we need to start learning how to respond to disasters, and pandemic influenza was perceived to be one of those things that they could respond to. So there was that big media frenzy around that, and then it dropped off again. So it disappeared again. So I think that you made an important point earlier, Dana. It's not just about getting things on the agenda, it's about keeping them on the agenda. And that's not easy to do. Suddenly, this year, we've got, of course, this new spike, and that's basically all in the last 2 weeks. And if you look at what's happened, this is just in the last 2 weeks, so we had nothing, 1 or 2, this is from all US media and newswires, we had absolutely nothing going on until 2 weeks ago, and then suddenly, boom, this epidemic of coverage. Now, the coverage is quite interesting because it's really cannibalizing itself. What you see is news articles that are referring to other news articles, that are referring to blog posts, that are referring to news articles, and there's a circularity of information and not very much new information. Now, because I thought we were quite time constrained, I didn't actually put the slides in here, but I've been looking also at what's been happening with blog coverage and blog hits and internet coverage. This morning, a Google search on the phrase swine flu would give you 24 million hits. 24 million hits. There's a blog, because I'm a nerd and I work a bit on epidemic flu, there's a blog that I follow which is called H5N1, so it's about avian flu, not about swine flu. And usually there are about 100, 120 of us a day looking at that blog. And in the last 2 weeks, that's gone to between 4,000 and 6,000 every day, reading a random blog about avian influenza. There's been so much news coverage, everyone's looking for a new angle, that one of the news stories now is about the news coverage. So we've got news coverage about swine flu. And I was asked, I got an email last week, I just copied it out here because from a TV station in the UK, because I'm a kind of bit of a media slut epidemiologist, so they call me whenever there's anything going on, even though I really only know about HIV. And this was from a national TV station, and they wanted me to do an interview, and they said, there are 2 schools of thought in our newsroom. Firstly, we're reporting an important story which the WHO considers so severe that it's raised the threat level to 4 and has called a number of emergency meetings. The second is that the actual number of deaths is perhaps not reflected in the level of coverage. Now, I think that that's an interesting reflection of the difficulty that journalists have very often in determining how real a story is. So they're saying, wait a minute, are we beating this up? Beating up a story is a journalistic term for basically taking some egg whites of old, tired news stories and whipping them up into a great froth and lather of media interest. It means making a big story out of something that's really not that big. And their concern was, are we beating this up? And for me, it really depends on your point of view and where you're standing in this spectrum of scientist to policymaker, and where do the journalists come in? So we've got these different things going on. On the one hand, one of the reasons you get these mixed messages, is it a big story, isn't it a big story, is because proper scientists, real scientists, people who are still doing the lab work and the research, people such as yourselves, are very hesitant to be definitive. Why? Because most of our research is not definitive. Most of it is we want to hedge our responses to the media around with reflections on that truly reflect the inaccuracy of our assumptions. So you can say, someone will call me and say, you know, is this an epidemic, yes or no? And I'll say, well, at the moment, while the transmission rate appears to be high, the mortality rate is low, but were there a mutation that we could eventually, perhaps, potentially reach something that would be similar to the 1918 flu epidemic? And what does that translate into? This, you know, you can hedge it about all you want, and then it gets translated into a headline that tells us that a pandemic is imminent. So scientists are very often not good at delivering what the media need, which is short, sharp sound bites with a high level of certainty. Of course, the other people you have are public health officials. Most of us who have been public health officials were once real scientists, and some still are, but we do have other agendas. Once you're a public health official, you have agendas which can sometimes actually be conflicting in themselves and contribute to that sort of mixed message that you get in the media. So if you've got a panic like this, and we do know that there is a real possibility of pandemic influenza in the world. We do know that the influenza virus mutates very rapidly. H5N1, I think, is the one to be frightened of. At the moment, it's not transmissible between humans. If it becomes so, we could have a real problem. And a panic like the panic about H1N1 allows us to prepare for that, allows us to put systems in place, allows us to get budgets raised, allows us to hire more staff. So it allows us to push things through. So even if you don't really believe that this one is a big deal, you're going to take advantage of it as much as you can to get what you need out of it. On the other hand, and this is particularly true of people in international organizations, but not exclusively, you've got the problem of needing to tread the fine line between not saying, well, we failed really badly. You know, you can't put it out there and say, well, actually, yes, this is a disaster because we haven't got any preparedness there. And saying, but actually, we do need more resources for more preparedness. So particularly, I mean, international organizations, WHO, are in a real bind because can you imagine in the private sector that you had the board of executives and the board of directors and the shareholders being exactly the same people? You know, it would be an impossible conflict of interest, but that's the situation in the WHO. You've got essentially the member states, the board of directors, being the same as the shareholders, the member states. So when you've got a situation like you've got at the moment, Mexico's sitting there on the board, and you're going to say, oh, don't travel to Mexico, you know, it's not worth it for now. Well, you can't do that. You know, tourism is their single biggest industry, besides perhaps drug production these days, but we don't evaluate that very well. So, of course, the WHO isn't going to be able to say that. So you've got all of these constraints as a public health official, which sometimes means that you put out mixed messages. From the point of view of journalists, I mean, to be honest, most public health officials know that most journalists didn't go into writing as a lifestyle because they were brilliant science students. So there are very, very good dedicated science reporters. There are many of them, and they do a great job. But they're not the people who are reporting a story like swine flu. 24 million hits, that's a lot of people who are out there reporting something that they essentially know nothing about, who don't know the difference between prevalence and incidence, who don't know all of those carefully worded things that scientists come out with get lost because a lot of journalists don't really understand what it is and don't have the ability to be critical and to challenge public health officials on the details. Well, what is the mortality rate here? What is the case detection rate? How many of these estimated infections actually have been reported, etc.? People don't know enough to be asking those questions effectively. The other thing is that journalists do tend often to take themselves quite seriously, and this is certainly true of North American and of many Northern European journalists. So my belief as a former journalist is that journalists' duty is to report, but a lot of journalists feel that their duty is to inform. And those are two different things. So when you're informing, you feel that you need to give people a sense of what they should do to prepare themselves against this, you know, terrible thing, and et cetera, et cetera. So it's a very easy channel, a very easy conduit for public health officials to use to put out there messages which are not necessarily directly relevant to the pandemic that we're writing about. Journalists, of course, have another duty, which is to their employers, and those sometimes go in opposite directions. So, I mean, how is it possible that cable TV last week was running 17 hours out of 24 on one story, swine flu? It's like, how can people watch that much? Well, because the more scared you make people, the more likely they're going to be to tune in once every couple of hours for an update. And every time they tune in, your ratings go up and your advertisers pay you more. So we need, to a certain extent, to have some stories that are beat-ups because it keeps our advertisers and therefore our publishers happy, and it keeps us in a job. So I think that the role of journalists is not as simple as very often it's seen to be. I think that also this particular, one of the stories that was run, it was a Reuters story just last week about the coverage of swine flu, contained this, this quote, and I know you can all read, but I'm going to read it to you because I think it so perfectly demonstrates the classic prevention dilemma. The media tends to love doomsday scenario like bird flu, and actually, I've put ... but they also mentioned the that guy with TB who was flying around the place was the exact quote. But very often these things don't pan out, and the problem is we're becoming like the boy who cried wolf. Now, nowhere in this story, which was 800 words long, did it consider the fact that maybe things don't pan out because of the media hysteria and the measures that are put in place as a consequence of that. So maybe things don't pan out because we're doing the right things. SARS, for example, could have been very, very much worse than it was, except that the government of China shut down once it got on board with the fact that it had a problem, and that took a while and a lot of media hysteria to make them recognize that. But once that was recognized, they shut down the capital city, a city of 20 million people, for 2 weeks. Bam. Everyone who went through an airport in Asia, probably many of you, were screened. Everyone, we had travel restrictions, we had all kinds of things which normally we wouldn't tolerate because there was a fear of SARS, and everyone was like, oh yeah, this is what it takes. And because of that, possibly, we didn't have a major epidemic. Now, it's the public health prevention conundrum is always, how do you prove that you've prevented something? Because if you do the right things and you shut it down, then everyone says, oh, look, it was all hype, you were just trying to get money for something. So you can't ever prove that this was all worthwhile. So now we're going to say, oh, well, you know, swine flu, it didn't pan out. Well, possibly part of that is because we've done the right things. I reflect sometimes on what would have happened if SARS had first arisen in a country that was a big, chaotic, decentralized democracy with a crappy health system, like Indonesia or India or the United States. I think that we were lucky that this thing actually surfaced in China, because public health is essentially very often quite a fascist discipline. It's a difficult thing to acknowledge, but sometimes, particularly if we're talking about pandemics of infectious diseases, it does mean restricting the rights of individuals in order to prevent a greater spread. And the media helps us do that because it helps people to be aware that this is bad enough that maybe they're going to have to accept some restrictions. For me, this slide basically is the crux of my thinking about pandemics and social collapse, which we haven't talked very much about, but was the theme of this session. The fact is that if we do the right things, pandemics of epidemics of infectious diseases don't pan out. This is data from 3 countries that have national needle exchange programs and 3 countries that don't. And you can see that those who have chosen not to do what it takes to prevent HIV among drug injectors have 1 in 2 injectors infected. 1 out of every 2 people infected with a completely preventable fatal disease. The people who have bothered, the countries that have bothered to do the right thing, don't have an epidemic in that population. Now they're faced with the problem that people are trying to cut budgets for prevention because they say, oh, well, we don't really need this. We don't have an epidemic. It's like, no, we don't have an epidemic because we're spending money on giving people clean needles. So again, you come back to this difficulty of supporting public health prevention. I want to talk a bit more about HIV because I think there's a real contrast between what happened in HIV and what's happening in swine flu and the other infectious diseases which could affect us all. Just so that we're all on the same page, we talk about the global HIV pandemic, but there is no global pandemic. There are essentially 2 separate epidemics. One is in East and Southern Africa, and it accounts for, it's an area that accounts for 10% of the world's population, 66% of current HIV, about 3/4 of deaths, partly because of differential access to drugs, although that differential, I'm glad to say, is shrinking. And so far, about 40 million infections, of whom a goodly proportion, sadly, have already died. In the rest of the world, as you can see, there's not much going on. Oh, hang on a second. Yes, there is. It's going on in very well-defined subpopulations. It's going on among drug injectors. It's going on among men who have sex with other men. It's going on with people who sell sex and people who buy sex. And very often in those populations, we have higher rates than we have in the adult population in sub-Saharan Africa, where HIV is spread by a population, by a behavior that the majority of the population engage in, which is sex between 2 adults of the opposite sex. Now, that brings us to the bare facts about the HIV epidemic, which is that HIV is a not very infectious virus that spreads essentially between people who have unprotected sex with several partners within a given 3-month period, and that's because of the way the viremia works, and if anyone wants to talk about that later, I'd be happy to, or who share needles in that time frame. And globally, the people who are most likely to do that are gay men, men in jail, drug injectors, and people who sell sex, and to a lesser extent, people who buy it, and adults in East and Southern Africa. Now, that's what the data say. But of course, that's not what public health officials said for years and years and years. Why? Because it's an incredibly difficult thing to say. It's politically incorrect. There are no votes in it. It's stigmatizing of the very communities who most need the help. And there's actually no money in doing nice things for junkies. And of course, to say that people in East and Southern Africa are more likely to have multiple sex partners in a 3-month period than people elsewhere in the world is considered to be racist. Now, I thought racism was something that was something that was applied to saying bad things, and how it's a bad thing to have sex with multiple partners, to have more sex is a mystery to me, but there we go. But what happened, essentially, was that we couldn't speak those truths. And so we really had a very difficult time in getting the money that we needed to deal with in this epidemic. So in the US, they did get a lot of money very quickly. We're talking up to 95, 96, the beginning of UNAIDS here. But globally, in that period, we had less than $300 million a year to deal with HIV globally by the time that UNAIDS was formed in 1995. Now, what was the difference between those two things? Well, I'm just looking at media coverage here in the New York Times because we saw that it was such a good bellwether of what's going on. But, oh no, actually, Yes, it is New York Times coverage. And you can see there was a huge peak in 1986. That was because Reagan and the Reagan government finally put together an AIDS plan at that time. And as a result of the frenzy of coverage around that, possibly, the spending continued to rise. Stories about HIV anywhere outside of the United States were not on the agenda. It just wasn't on the agenda. So there we are, sitting in UNAIDS in 95, 96, thinking, hang on a second, maybe we need a beat up like that. Maybe we need a scare like that. Maybe we need to repackage this epidemic in a way that we can sell it to people who will give us money to deal with it. Because you cannot deal with an epidemic on that scale around the world for $350 million a year. So what did we do? We repackaged the problem in two ways. And actually, Diane gave an example of one way earlier on, which is to say, actually, it's really good value to do effective prevention. Because if you concentrate your prevention resources on these groups at high risk now, you will prevent a whole lot of costs of treatment later on. Now, this was before we even had widespread antiretroviral treatment, but even just treating opportunistic infections, the cost to the workforce of early adult death, et cetera, et cetera. So that was one argument that we used. It didn't work. Why not? Because in a democracy, the fact that if you do something that's politically unpopular now, if you do something that will lose you votes now, if you do something that will get you voted out of power now, it doesn't matter that you'll save money 10 years from now, because it'll be another government that's saving the money. So actually, that good value in the long-term thing is not something that plays very well in a lot of democracies. I need good value before the next election. The votes argument was a little more successful in terms of getting attention. And that was, we need to focus our HIV prevention on these, quote, vulnerable populations now, because if we don't do that, we are going to see more transmission in the general population. So if we don't focus on gay men, on drug injectors, and commercial sex now, then we're going to see innocent women and children affected later on. You can always get money for innocent women and children. So the subtext of that second argument was, HIV is coming to get you. So right now, it may not be something that you care about. You think it's about hookers and gay guys and junkies, but actually, if you don't deal with it in those populations, it's coming to get you. Well, it kind of worked. So we had campaigns like this. AIDS can affect anyone. But of course, that actually got in the way of our ability to do the things we needed to do. Because we don't need programs for everyone. We don't need universal access. We need universal access for that minority of people who engage in the behaviors that put them at risk for HIV, which in every continent outside of sub-Saharan Africa are quite well-defined populations that between them don't add up to 10% of the population. But there were good things in the everyone at risk thing. I mean, it makes everyone happy, basically. The AIDS mafia, and I count myself as a card-carrying member of the AIDS mafia, are happy because it did bring in more cash. Governments are happy because they can be seen to be doing something about HIV without having to do nice things for drug injectors and all the other icky groups that are affected. The UN and NGOs are very happy because they can get cash even though they don't want to deal with or they don't deal with the things that really put people at risk for HIV. So you notice there's no UN sex. Although, we do have a UN drugs. They don't deal with drug injectors, but we do have a UN drugs. But these organizations who are dealing with fisheries and with agriculture and with migration and with this and that suddenly can all get access to the AIDS budget. So that was nice. AIDS activists were happy because and we're a big part of the voice actually supporting the everyone is at risk thing in Western countries, because it meant that you were removing the stigma associated with the groups that were most at risk. But there comes a point where you say, hang on a second, if everyone is at risk and that means that our whole prevention effort is going down the wrong road, then we're not providing the services that we need to the populations that are most at risk, and so they're going to become more infected and more of them are going to die. It's like, what would you rather be, stigmatized or dead? But hey. And HIV, of course, can go on spreading in those situations, so it's good for HIV too. Okay, we actually use data to support all of these contentions, and here's a wonderful piece, a slide that I made some years ago, looking at the proportion of infections in Cambodia. So we said, okay, it used to be concentrated in the commercial sex trade in Cambodia, but now it's really affecting innocent women and children. So you can see what's going on here is that the light blue is clients of sex workers, and the dark pink is sex workers. And early in the epidemic, it was really all about sex workers and their clients. But over time, you can see that clients are infecting their innocent wives and eventually their children. And so what we really need to do, and in fact you've also got former sex workers then going on and infecting their new husbands. So really we shouldn't be concentrating all of our prevention resources on just the sex trade in the Cambodian situation. We really need to be doing things for the general population because it's all nowadays about innocent women and children. Okay, this is an example of what is known as torturing the statistics. Because if you torture the statistics enough, they will confess to anything. If I show you exactly the same slide with absolute numbers rather than standardized proportionately over 100%, you'll see that what's happening is that, yes, you've got a higher proportion of infections in married women than before, but because we've effectively concentrated our prevention efforts at commercial sex, because condom use in commercial sex has gone from less than 20% to over 95% in a 4-year period, because HIV prevalence has come down in sex workers, we've essentially wiped out the epidemic in Cambodia. So, in fact, yes, there are more proportionately pregnant women or married women at risk, but actually, because we've done the right thing, concentrated our resources, we've wiped out the epidemic. Now, this doesn't make such a good story for donors as it's all about women at risk. Unfortunately, that everyone's at risk thing really makes us do some pretty dumb things. So this is the proportion of exposure, risk of exposed contact in southern China. And you can see that almost all of it is in drug injectors. Now, where are we spending our money? Well, we're spending over half of our external finance money on programs for the general population, which accounts for less than 2% of our exposure. And that's because the UN agencies, NGOs, absolutely just as guilty, are banging the drum of everyone's at risk. So I have a program for school kids, I have a program for pregnant women, we need HIV money because we can get it. But it's not an effective way of addressing this epidemic. Now, sub-Saharan Africa is different because when you've got rates like this in the general population, you can really argue that everyone is at risk. This is one indication why that might be. These are data that were collected in 1989 and 1990 in household surveys in a number of sub-Saharan African countries, but also in other parts of the world. And you can see that the number of people who are reporting simultaneous concurrent is the current fashionable word. Concurrent long-term partnerships is much, much higher in sub-Saharan Africa than anywhere else in the world. I just want to point out one interesting thing about this slide, which is completely off topic, but I think it's so interesting. They asked people, men and women, do you have more than one current partner? And then they asked, and do you think that your partner, opposite sex partner, has more than one current partner? And what you see here is that women all think that men are devils, because women all think that men have more partners than they actually report, and men all think their wives are angels, because men are much less likely to think that their wives have multiple partners than they really do, than they admit to even. So I think that's quite interesting. But really, this was a very difficult thing in the context of the late 80s and early 90s to put out there. Hey, it's about different patterns of sexual behavior, and we need to really address this. So we found alternative explanations. We had to repackage it, and what did we come up with? HIV is a development problem, it's about migration, and my favorite, poverty and gender inequality spreads AIDS. That is a direct quote, a headline from an otherwise actually quite good report from the World Bank called Confronting AIDS. Poverty and gender inequality spread AIDS. And there was I thinking you got to have sex, but no. Apparently you can get HIV just by being poor, or just by being gender. What does that mean? Female, I think, in this context. But the subtext of this whole rewriting of the reality was, actually, it's not about individual risk. It's about big out there things like poverty and like gender inequality and like all of these things, which you as an individual can't do anything about. So let's not worry about individual programs. Let's just focus it all on, poverty reduction plans and et cetera, and that will take care of the HIV problem. And of course, that's not true either. I would say that HIV is a development problem. The most developed countries in sub-Saharan Africa have a lot more of it than the less developed countries. Countries with higher, I took the slides out because of time, but countries with higher rates of gender equality have higher rates of HIV. This is per capita GNP along the bottom here, and HIV prevalence in the general population up the side, and you can see that there's a fairly straight regression line through those with an R squared of 0.8 something. At the household level, it's also true that we've got more higher rates of HIV prevalence in richer households compared with poorer households. These are data from demographic and health surveys, DHS surveys, which I'm sure you're all familiar with. So yes, HIV is associated with economic indicators, just not necessarily in the social meltdown, social collapse sort of way. That whole repackaging thing did work in terms of money. So the earlier slide I showed you was to where UNAIDS comes in there, to 1996, and since then there's been this dramatic takeoff in the amount of money that's become available for HIV. Now this includes care as well as prevention, but if you take the care out of it and just look at the prevention bit, I mean, you've got this massive ramp up. Now how does that translate into fewer new infections? Well, when I started at UNAIDS in 1996, we had about 2.5 million new infections a year, and then it rose to just over 3 million, and now it's back down to, just about 2.5, 2.7 million new infections a year. So in that time that we've seen this massive ramp up of money, the only thing that's really changed is the cost of our prevention failures. We used to fail at the cost of $70 per new infection, and now we're failing at a cost between $2,000 and $3,000 per new infection. Now, UNAIDS does see some hope on the horizon, and this is a classic example. This is the press release that went out with the last UNAIDS global report, which was issued before the Mexico conference last summer. And it's a classic case of a mixed message headline, and illustrates really well, I think, the fine line that public health officials have to walk between, okay, substantial increases in HIV prevention efforts producing results, so we're doing a good job with all the money you've given us, but not enough to turn back the epidemic, so please give us some more money. So I think it's a good example of that fine line. Now, what's interesting is the example, one of the two examples that they single out in the first paragraph of their press release for HIV prevention success, Zimbabwe. Now, let's see. Think about what's happened in Zimbabwe over the last couple of years. Is the first thing that leaps to your mind great HIV prevention programs? Or is it maybe 250 million% inflation, the whole of the health sector on strike, everyone who can afford it possibly going to South Africa or Zambia for their meds, no one much hanging out in bars and getting laid anymore because no one can afford to go out drinking? Maybe it's that. So in fact, possibly, I think we need to look at the data much more carefully, but maybe there's a case that we need more social collapse, and that's an effective HIV prevention tool. I'm being a bit facetious, but not very. So back to my original question is, can we create pandemics? Well, I think that we've seen that from the point of view of the media, yes, we can. In the short term, you can beat something up, get a lot of attention. That does create opportunities to create preparedness. It does create opportunities often to get some structures in place that may last in the longer term, but it never really lasts very well as a sustained response. But in reality, can we create pandemics? I would say yes. I would say that the HIV epidemic is a created epidemic. How did we create it? By negligence. We created it by failing to stop it. We did not stop HIV because we did not care enough to do the right things at the right time. Voters did not care enough to demand of their governments that they invested in programs that would save the lives of drug injectors, of gay men, and of people who injected drugs, and of people who bought and sold sex. And in the sub-Saharan African context, people didn't demand of their governments honesty about what was going on here. How come I'm suddenly going to a funeral every 3 weeks, 2 weeks, every week, 2 on a Saturday? I mean, how come that's happening? What is going on here, and what are you doing about it? That governments never drew, with some notable exceptions, and the most celebrated one was Yoweri Museveni in Uganda, who sadly seems to have suffered a bit of a reverse of conviction, but early in the epidemic certainly drew a very, very straight line between unprotected sex with multiple partners, HIV infection, AIDS disease, and death, and was the only African leader to do that for quite a long time. That straight line hasn't been drawn until now by some prominent governments in East and Southern Africa, and no one was demanding it of people. So I think that, yes, you can create an epidemic by failing to do what it takes to stop it, even when you know what that is, by failing to care enough. Then will pandemics cause social breakdown? I think almost certainly not, because any pandemic, the long shadows that are being cast by these emerging diseases, essentially, if they threaten enough people to cause social breakdown, then the press will be all over it. Governments will react very rapidly, as we've seen in the case of SARS, as we've seen in the case of avian flu, as we've seen in the case of swine flu, because that can threaten us, the voters. You do put things in place. People do accept restrictions on their liberty, on their travel, and all these other things, and things will get stopped. So I'm actually not that concerned about the huge, massive social consequences. I am concerned about emerging infectious diseases, not least because it keeps people like me in a job, so, please keep them emerging. But I'm also, I believe very, very strongly that we can, as perhaps not a global society, but as individual societies, we can demand a strong enough response to stop there being a repetition of something like HIV. One thing that I will say that this whole rash of pandemic awareness has done for me is to actually make more people aware of what I do for a living. I used to say epidemiologist, and they'd kind of go, ugh, take 3 steps backwards thinking it was something horrible to do with skin. And now we've made it into the cartoons of the New Yorkers, and we get invited to interesting conferences like this. So thank you very much.
Thank you very much, Elizabeth, for a very nice presentation. And now we open for questions and comments. Yes, the epidemic, do you really think it would be possible or feasible to stop an influenza, highly contagious influenza, if we tried to?
Yes, I think it would. Yeah, I do. Mm-hmm. I mean, we stopped SARS, essentially. I mean, one of the things that, sorry. Yeah. One of the things epidemiologically, I mean, influenza is a difficult one, but essentially very virulent viruses don't usually do very well. Because if you create, I mean, SARS was acute, and it was highly infectious, but it was very acute, and it was very severe acute respiratory syndrome. And so you have, if it's too severe and too rapid, it actually doesn't have that much opportunity for spread. One of the brilliant things about the design of the HIV virus is that it has this extremely long latency period, which allows it to spread very quickly. But if we had something that was very, very severe, it would be, to a certain extent, self-limiting, and with the impositions, which I think that the SARS epidemic has shown us, people are willing to accept, yes, I think that we would stop it.
Okay, and then to both speakers, yeah, there's a question there. Okay, thank you.
Okay, I have to ask this question. We had this discussion yesterday. I think that the Zimbabwe case is very interesting because it tells us about the problem of the media and science in a situation where you have a sort of a governance problem. So you have such a polarization that we can explain almost anything by autocracy, dictatorship, by certain types of general variables, such that we don't now examine the issues very clearly. And HIV/AIDS is one of those statistics. Statistics in Zimbabwe are so contested. Whether you're government, there's less malnutrition and so forth. If you're IMF and so forth, you know, depending on which side you are, you have this problem of presenting the social collapse. And I think we should look at that carefully. Now, the HIV figures are interesting because we have a democracy, two democracies on the side, Botswana and South Africa. We've got not so democratic Zambia, Mozambique, and so forth, all within the same range of problem with this, in terms of the evolution of the disease. And now suddenly you have a sharp decline in Zimbabwe, and thank God the study was done in England from an English university, not from Zimbabwean scientists, let alone government scientists. So we have this dilemma, so how do we explain this? And I must say, and we had this discussion yesterday, nobody really has the courage to go deeper, to do the science, to explain why this is. And this may be to do with longer-term structural change, social structural change of the early 80s, 90s, the level of education, the demographic shifts, family size, fertility, and so forth and so forth. And of course, the data that we have of the issues, the things that are being used to explain it are very unreliable. Emigration, the numbers, who is emigrating, no good data, and so on and so forth. So this is one of those cases which says that we should invest more in science to examine issues, even when we have obvious repressive situations in which the politics is so highly polarized on a global scale. Thank you.
I agree with you 100%, and you know, I put the Zimbabwean stuff in for your benefit, but it's I do think that you're absolutely right that we need to look very, very carefully at the data in these cases. I think that it's very, very easy to draw these conclusions and to make sweeping statements. I mean, example. Also from Southern Africa, I was called by a Canadian radio station. Would I do an interview on the impact of, it was last summer during the very high spike in food prices. Would I talk about the impact of food insecurity and rising food prices on HIV, because obviously it's fueling the HIV epidemic? I was like, huh? How does that work? Oh, yes, no, we had someone on this morning and they said that because food prices were rising, more women in Southern Africa were having to sell sex, so it's fueling HIV. And I was like, oh, that's so many different types of wrong, I hardly even, but anyway, and we don't have any data, obviously. But number one, heard of the phrase breadwinner? Generally, sex is a commodity, just like food. It is a commodity that people arguably can do without. Paid sex is a commodity people can do without, unlike food. So if you have a crisis in food, people are going to prioritize that over paid sex. That means that demand falls before, demand for sex falls. If supply also increases, you get a dilution effect, which actually epidemiologically leads to a reduction in HIV transmission, not an increase in HIV transmission. Do we have any data to support that? The only stuff that I'm aware of is from Indonesia, a country where I've done a lot of work, where in the complete chaos, krismon, they call it, the monetary crisis of 97, 98, we saw a remarkable drop in the proportion of men buying sex, an increase in the estimated number of women selling sex, and a consequent reduction in sexually transmitted infections. Now, just to illustrate that you're absolutely right, that these things are not as simple as the knee-jerk, politically motivated response generally would suggest. If you dig into the data and if you scratch around what's going on, you very often get a more sophisticated understanding. And I think time will tell what's happening now in Zimbabwe. I would say that Zimbabwe was different from several of its neighbors until not very long ago, to the extent that it had really a very strong public health infrastructure, and one that was particularly focused on effective monitoring and response to sexually transmitted infections other than HIV. And I think that that probably helped, but who knows?
Thank you. One last question. Okay.
Thank you. My name is Joseph Shammy. I'm a demographer. These are very good presentations. I wanted to say that first. We know that people die, whatever you do. Eventually, they're going to die. My question, and I can give you my own thoughts on this briefly, what do you think about a 1914, 1918 scenario that we had with the Spanish influenza happening again? Although we do have technology and drugs and so on, the social and political individual behavior that occurred at that time that you've indicated still persists. So do you think really if we got some good bug like we did in the beginning of the century with billions of more people, that really the society, individual behavior and political behavior would be such that they could really deal with this thing and not prevent a global pandemic? My own view is things haven't changed that much. The political systems and individual behavior are essentially the same as they've been in 1914, 1918. So I'd appreciate your thoughts briefly. Do you really think that we could deal with a bug that came out like we did in the beginning of the 20th century at this point?
Yeah, I think you'll probably have something to say about that as well. I see one very big difference, which is that we're not currently in the throes of a world war which is disrupting social structures as we have previously known them. Yes, our social structures currently are much more fluid now, and so we have similar levels of mobility and etc., but it's not a disruption. As I meant to point out with my final slide there, I think that social collapse and epidemics have a shared godfather or shared parent, actually, which is very bad government. And I think that at the moment we don't have enough. We've got plenty of bad government around the world, but not on a global scale. I think that there's enough good government to be able to shut something down fairly effectively, and I don't think that that was the case in the flu pandemic of the first part of the last century.
Dana, would you like to comment? I think it's a little. Perhaps you should list that
I can't really comment from the influenza side. I think we do know that you commented that the thing that's the same is people's behavior, but I think the thing that's also the same is that the bugs are tricky beasts. And I think they were tricky beasts back there, and they're tricky beasts today. And so I think the concern for all of us is the mutation, I think probably. And from our experience, for example, in TB, and even as we think about HIV and drug resistance on the HIV front, as I think, there is an evolution of the bugs. And I think that's what concerns us all, which is why preparedness is the way to go. In terms of the way the world works today, I would say that we do have more means to communicate, more means to collaborate, more public health measures, for example, the international health regulations, which have been a big asset right now in encouraging and basically putting some teeth into the need to report cases. So I think we are in a different place than we were then, and I think also we have a different communication modes. I mean, I think it's tremendously impressive to see how far cell phones have penetrated and how quickly information about unusual events is being transmitted and how creative people are being, even at the local village level, tribal villages that I just saw, where cell phones are in use. So I think some of these things are dramatically different. But as you said, some behaviors are quite similar. So I think we need to be concerned, but our ability to prepare, I think, we're at a different place today.
Thank you very much. And then I will have to say thank you to both speakers and to the audience, and then we will have lunch. Thank you very much.